It's time for another warm-up. Let's get going. First question here, which spinal tracts convey the following information? So first we have pain and temperature sensation. That's going to be the lateral spinothalamic tract. Important for postural adjustments and head movements. That's going to be the vestibulospinal tract. Then we have proprioceptive information to the cerebellum. That's going to be the dorsal and ventral spinocerebellar tracts. Next, what molecules are expressed on the surface of antigen-presenting dendritic cells? So we have MHC1, MHC2, a B7 co-stimulatory protein, so CD80 or CD86, and then you have CD40, which is a co-stimulatory protein as well. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
Good kitty. You're a pretty little kitty. Yes, you are.
Oh, we're ready to start taping? In this video, we're going to talk about the ear, including both the cochlear apparatus for hearing and the vestibular apparatus for balance and sensation of head position. This is some relatively lower yield stuff, but some of this does turn up on step one. Let's talk about hearing first. How does your ear convert sound vibrations into a neurological signal that the brain can interpret? Let's review the functional anatomy of the ear in the normal auditory pathway. This is maybe 2 stars, but it is definitely fair game. Auditory sensation starts with the tympanic membrane, which separates the external ear canal from the middle ear. Now, the bone that butts up against the tympanic membrane in the middle ear is the malleus, and that's connected to the incus, which is connected to the stapes, which is in turn connected to the cochlea. So when a sound makes the tympanic membrane vibrate, those vibrations are transmitted to the fluid inside the cochlea by this series of 3 bones. Now, the vibration of the cochlear fluid causes movements of the auditory hair cells, which are specialized receptors that perceive this vibration. There are inner hair cells and outer hair cells, which have different functions. Let's take a short detour right here for just a second. We'll pick back up here in a moment and finish following the signal all the way up to the cortex. But first, I want to mention a couple of testable points about these hair cells. When we talked about muscles and reflexes, we said there were intrafusal muscle fibers and extrafusal muscle fibers. And you could sensitize muscle fibers with gamma motor neuron innervation. That signal comes down from the brain and tells the sensory organs within the skeletal muscle to be on alert for any input. Well, you have a similar mechanism in your ear. There are efferent fibers from your brain that go to the outer hair cells of the cochlea to influence the sensitivity of those outer hair cells. These are the olivocochlear bundles, which run from the superior olive of the brainstem to the cochlea. These bundles send cholinergic signals to the cochlea, which result in contraction of the outer hair cells, and that results in stiffening of the basilar membrane inside the cochlea, which sensitizes the inner hair cells to a particular frequency. And the reason that aminoglycoside antibiotics like gentamicin cause hearing loss is that they can potentially damage those outer hair cells. Now let's get back to the auditory pathway. When a sound vibration stimulates the hair cells in the cochlea, they generate a nerve signal. And that nerve signal travels from the cell bodies of the spiral ganglion, or the cochlear ganglion, to the cochlear nuclei in the brainstem. Then that signal decussates to the contralateral superior olivary nucleus, and then travels up the lateral lemniscus to the inferior colliculus, and then to the medial geniculate nucleus in the thalamus. Remember, M for music, M for medial geniculate nucleus. And then finally, the signal goes to the primary auditory cortex, which is located in the temporal lobe. Let's talk about hearing tests like the Weber test and the Renna test. These aren't incredibly high yield, but students have reported seeing questions in which they're asked to interpret these tests, so we've got some practice for you. The Weber test and the Renna test can help you diagnose conductive hearing loss or sensory neural hearing loss, and which side the hearing loss is on. And both of these tests work together. So first you do the Weber test. You strike the tuning fork and you place the base firmly in the midline of the skull, either on the top of the head, maybe on the forehead. It could be anywhere in the midline, between the eyes, on the maxilla, but usually we just put it on the top of the head. Then you ask the patient, do you hear anything? The patient says yes. Then you ask, which ear do you hear it in? And normally the patient's going to say both. And if it's louder in one ear than the other, that's abnormal. Now, don't write down that Weber's test is positive or negative. That's potentially confusing. You should write down Weber midline, which is normal, or Weber lateralizes to the right or to the left. In the study guide, there's an explanation of how to interpret the Weber test. Midline is normal. Both ears are working. Conductive hearing loss lateralizes to the side of the affected ear. Sensory neural hearing loss lateralizes to the side of the good ear. So think that through. If you have conductive hearing loss, the sound is louder in that ear. Try it out. You can give yourself conductive hearing loss by plugging your ear, and then try the tuning fork, and it should be louder on that side. You can use that to help you remember that conductive hearing loss lateralizes to the affected ear. If you have sensory neural hearing loss, you won't hear anything on the affected side, so the sound lateralizes to the good ear. So when you do the Weber test, all you know is that the sound lateralizes to one side or the other. You can't tell whether it's conductive or sensory neural hearing loss yet. You have to do more testing to figure it out. That's where the RENA test comes in. In the RENA test, you test each ear separately. So you strike the tuning fork and you place the base on the mastoid process just behind the ear. And you ask the patient if they can hear the tone. The patient says yes. Then you tell the patient to let you know the very instant the sound disappears. Depending on how hard you struck the tuning fork, it may take a little while, 15 to 20 seconds. Don't get impatient. Then as soon as the patient tells you that the sound is gone, you move the fork to just outside the opening of the ear canal, and the U of the fork should be facing forward. And then you ask the patient, do you hear it now? So look back at your study guide. Normally, air conduction is better than bone conduction, so the patient should still be able to hear the tone faintly immediately after the fork is moved from the mastoid to the canal. And you record this as air conduction greater than bone conduction on the right. If the patient can't hear the tone after you move the fork, that's abnormal. That means that bone conduction is greater than air conduction. And you record bone conduction greater than air conduction on the right. Don't say RENA test positive on the right or negative on the left. Again, it's too easy to misinterpret. So with conductive hearing loss, bone conduction is greater than air conduction. But you can't do much with the RENA test by itself, because with sensory neural hearing loss, you're still going to get a normal RENA test result. With sensory neural hearing loss, the tone should still return after you switch it, because air conduction is still better than bone conduction. The problem's not conductive. So you really need to do both the Weber test and the RENA test. And you need to test each ear independently, because they may have slightly different findings on each side. So now let's get some practice interpreting these. We've given you complete results of the Weber test and the RENA test on each side, and you have to figure out whether the patient has conductive loss on the left or sensory neural hearing loss on the right or whatever. So pause the video and try to figure these out. All right, here are the answers. Patient A's Weber test is midline, and that's normal. And air conduction is greater than bone conduction in both ears, so that's normal. So the diagnosis here is normal. In patient B, the RENA test is normal on the left with air conduction greater than bone conduction. But in the right ear, bone conduction is greater than air conduction. That's a huge flag that something's going on with the right ear. This indicates conductive hearing loss in the right ear. And our Weber test confirms that. Remember, in conductive hearing loss, the Weber test lateralizes to the side of the affected ear, so everything matches up. In patient C, the RENA test is normal on both sides. So we're done, right? Wrong. This is how you get fooled if you try to hang your hat on one test without the other. The Weber test is abnormal because it lateralized to the left. So maybe that means there's a conductive hearing loss on the left, because with conductive loss, the Weber test lateralizes to the side of the affected ear. But no, the RENA test is normal, so you can't have conductive hearing loss. So if the Weber test lateralized to the left, that must mean that there's sensory neural hearing loss on the right side, because in sensory neural hearing loss, the Weber test lateralizes to the side opposite the affected ear. So you see how important it is to do both tests. And in patient D, bone conduction is greater than air conduction in both ears, but the Weber test is normal. So in this case, you have bilateral conductive hearing loss. So that's how you interpret those. Another type of hearing testing is audiometry, where they put the headphones on you and play the electronic beeping sounds. And audiograms are tested on both USMLE and COMLEX, so you definitely need to know how to interpret these. An audiogram plots the lowest volume at which the patient can hear each of these different frequencies. And with normal hearing, both ears are about the same, and the sound is heard pretty close to 0 decibels. But if the graph for one or both ears dips way down, that tells you there's some hearing loss. Now, as you get older, it's pretty common to have some high-frequency hearing loss, as you see here. And you can also test bone conduction using a device that vibrates the bone. So on your exam, they might show you an audiogram in which the air conduction is abnormal, but bone conduction is normal, and ask you to diagnose conductive hearing loss. Next, let's talk about some inflammatory diseases of the ear, starting with otitis externa. Otitis externa is inflammation or infection of the ear canal. One of the hallmarks of this disease is that when you pull on the pinna, it causes ear pain. Even putting the otoscope into the ear can be very painful for the patient. It's most commonly caused by Pseudomonas, and then the second most common organism is Staph aureus. We typically call this swimmer's ear because it's associated with wetness in the ear canal following swimming. And the treatment is irrigation plus topical antibiotics, ear drops. Systemic antibiotic therapy is not necessary. This is a superficial infection just within the ear canal. Next is otitis media. Now, this is an infection of the middle ear space, which can be bacterial or viral. Both are really common. You diagnose acute otitis media by inspecting the tympanic membrane with an otoscope. The tympanic membrane may be bulging. You usually see fluid in the middle ear, so a middle ear effusion, which could be serous or it could be pus. Or you might just see erythema of the tympanic membrane. But be aware that erythema is not necessarily diagnostic of acute otitis media. Redness can occur simply with stress or even blushing. Another important clue is that the tympanic membrane is immobile under positive pressure with a pneumatic otoscope. So you blow a little puff of air into the ear canal with an insufflator and you look for movement of the tympanic membrane, because if the tympanic membrane is immobile, that's an important criterion for the diagnosis of acute otitis media. So what are the bacteria that can cause acute otitis media? Strep pneumoniae is one of the big ones. It's the most common bacterial cause of acute otitis media. Non-typable Haemophilus influenza can do it, not the type B that causes meningitis. This is non-typable Haemophilus influenza. And then Moraxella catarrhalis. So those are the three most common bacterial causes of acute otitis media. And then what antibiotics do we use to treat acute otitis media? Well, you can use amoxicillin. You can use amoxicillin plus clavulanic acid, or you can use cephalosporins. And for kids with recurrent episodes of acute otitis media, you may need to place tympanostomy tubes to maintain an equalized pressure. One of the complications to be aware of with acute otitis media is acute mastoiditis. So you should suspect acute mastoiditis in a patient with typical otitis media symptoms like fever and ear pain and irritability, plus post-auricular swelling and redness and tenderness of the mastoid process, that bony prominence right behind the ear. Another middle ear problem that shows up on step 1 from time to time is cholesteatoma. Cholesteatoma is overgrowth of desquamated keratin debris within the middle ear space that may eventually erode the ossicles and also the mastoid. So this is bad news. Now the name is kind of misleading. There's no cholesterol or lipids involved. They ought to call it a keratoma or something. And these aren't neoplastic or cancerous, so don't let the oma throw you. But these can be destructive and they can erode the ossicles. So what causes cholesteatoma? Well, there's negative middle ear pressure from eustachian tube dysfunction, and that negative pressure pulls on the tympanic membrane and creates a chronic retraction pocket. Or it could occur when there's a hole or perforation in the tympanic membrane and the epithelium grows through that perforation from the inside out. Now, cholesteatoma is commonly associated with chronic middle ear infection. On physical exam, you're going to see a grayish-white or pearly lesion behind the tympanic membrane, or possibly involving the tympanic membrane. And the patient may also have some conductive hearing loss or vertigo. Now, the first time I ever saw cholesteatoma, I looked in the patient's ear and I said, "What in the world is that? I don't know what it is, but it ain't normal." And I sent the patient to the ENT that day. The ENT recognized it and did surgery to remove it that same week. You don't want to mess around with these. So the treatment is tympanomastoidectomy with reconstruction of the ossicles. Let's talk about vertigo, which is a disorder of the vestibular apparatus. Vertigo is an illusion of motion, usually spinning or rotational movement. You'll see a lot of patients who complain of feeling dizzy, but dizzy is a fairly vague term. Sometimes patients will use the word dizzy to describe lightheadedness or presyncope, like they're going to faint. That's not really vertigo. Vertigo is a sensation of movement, like the room is spinning or like you're spinning. The most common cause of vertigo is something called benign paroxysmal positional vertigo, or BPPV. The precise etiology of BPPV is not entirely clear, but it's presumed that you either have debris in the semicircular canals of the vestibular apparatus or you have some otoliths that are misplaced. There are certain maneuvers you can do, like the Dix-Hallpike maneuver and the Epley maneuver, that can help you diagnose BPPV and then treat it. There are other peripheral things that cause vertigo, including vestibular neuritis, or inflammation of the vestibular nerve, or Meniere's disease, which is due to imbalances of the fluid and electrolyte composition of the endolymph, the fluid inside the vestibular apparatus. The classic triad of symptoms in Meniere's disease is intermittent vertigo, tinnitus, and hearing loss. Then there's also central vertigo, which is due to a brainstem lesion or a cerebellar lesion that damages the vestibular nuclei. Or posterior fossa tumors could potentially compress the cerebellum or the brainstem and cause some central vertigo. Now we're ready for the end of session quiz. Go ahead and pause the video, work through those. We'll go through them together. First question. Patient presents with vertigo, tinnitus, and hearing loss. What's the diagnosis? That's the classic triad of Meniere's disease. Next, which bacterial organisms are most commonly responsible for acute otitis media? We mentioned Strep pneumoniae, non-typable Haemophilus influenza, and Moraxella catarrhalis. Next, what bacterial organism is most commonly responsible for otitis externa? This is Pseudomonas aeruginosa. And the last one, chronic otitis media can sometimes result in a cystic lesion that's lined by keratinizing squamous epithelium, which could be metaplastic, that's filled with amorphous debris. What's the diagnosis? That's a cholesteatoma. That's it for now. I'll see you next time.